So, hi Tzvika, we are going to talk about headache and orofacial pain today. Can you tell us why we are dealing with this topic, how the prevalence is, or who is most commonly affected?
Well, hello. Headache and orofacial pain are very common. We're talking about 80% of the population that have headaches, at least one acute headache during their lifetime, and around 1/4 of the population, adult population, to have orofacial pain during their life. So it's a very common complaint. And actually, it's also there are some, it's really adjacent because orofacial pain and headache are both in the face and head, and sometimes they are mixing with each other. So we have a big overlap between orofacial pain and headache as well.
Yeah. And how do we classify these conditions?
Well, headache is mainly can be divided into primary and secondary. Primary headache is headache that we have no certain reason for the headache, so we cannot pinpoint what is the reason that you have headache, such as tension type headache, migraine, and cluster headache. So the main problem in primary headache is the headache itself. It's a pain condition. And secondary headache, like cervicogenic headache, or like headache that is attributed to temporomandibular disorder, is headache that is secondary to other classified medical condition. So this is the main classification of headache.
Mm-hmm. So if we are looking at the patients with headache or also orofacial pain, what are the red flags we have to look at, and what do we do with these patients?
Well, there are several red flags. The two main reasons for patients to have dangerous headache are mainly mass lesions and intracranial problems with the blood flow. So if something is going on with the vascular system inside the brain and inside the skull, it's very dangerous, and it can be the main complaint, or one of the complaints may be headache. And of course, if the patient has a mass lesion, a tumor or something, infection, something bad is going on inside his cranium, also one of the main complaints will be headache. So that's why we need to be very careful when we screen patients with headache, because potentially they can have a dangerous condition. Their main complaint would be a very acute headache, something that they haven't had before, something very new. Sometimes some neurological signs associated with the headache, or some other, so they may feel sick together with the headache, and it will not get better even if we start treating them, or if we are waiting for a while, it will not get better. So these are the main red flags. Also, headache that is new for someone that is older than 50, statistically can be a red flag just by itself.
Okay. If we rule these red signs out, what do we do with the patients? You said like the yellow and the orange field, we're going to see that on the slide. I can imagine that physiotherapy is helpful for those with musculoskeletal aspect, but what is the treatment for the other ones?
So the traffic light approach is an approach that can help us to classify patients in the musculoskeletal practice. And when they are classified into the red color, we have to send them to see quite urgently a medical doctor. It could be an emergency room, or it could be a doctor that is available today, but they should see someone quite immediately, because it can be something, if it's vascular event, it can be something very urgent. If it's a mass lesion, usually they have more time, but it's not our position to diagnose, but rather to say something bad is going on here, and for that reason you have to see a doctor immediately.
Mm-hmm. And the ones that we can treat, what about those? What is evidence suggesting about the treatment?
Do you mean those who have the headache that is not dangerous,
Yeah, exactly.
but is still nothing is something that we cannot help? Yep.
Yeah.
So we have in the classification and in the red in the light classification, traffic light classification, we have the green, and which we can treat, and it's musculoskeletal, purely musculoskeletal condition, and we have the orange and the yellow. So the orange and yellow are patients with headache that is not musculoskeletal in its nature, but the yellow signs that they have some musculoskeletal component in it. So there is something that can be done from us about it. But the orange is more to say that it's not musculoskeletal condition, but they also don't have a musculoskeletal component to it. Then we have almost nothing to offer to this patient, maybe just exercise prescription, general exercise prescription, but
Yes.
nothing more than that in a physio-wise. So
Yes.
these patients are like migraine patient without any cervical spine disorder, without any temporomandibular disorder, without active trigger points in her neck and in her masticatory muscles. What can we offer these patients? Not a lot. Probably it's better to send her to see someone else, maybe from alternative medicine, or maybe from or changing her diet, or the dietitian, or maybe medication, but probably not the physical approach will be the approach to help this patient.
Yeah, yeah. And what about those with clearly musculoskeletal conditions? What is
Well,
like the first treatment you do, or what is most effective?
we have two conditions that can be diagnosed by physiotherapists with a good reliability and validity, that are purely musculoskeletal to create headache. One is cervicogenic headache, and the other is temporomandibular disorder. For cervicogenic headache, the treatment would be treating the nociception from the cervical spine, and also addressing the contributing factors such as posture and deep cervical flexors, etc. So this is something using the dry needling will be very helpful for most of them, for muscles like splenius capitis, suboccipitals, semispinalis capitis, upper trapezius, also some manual techniques for their upper three segments, and again, a retraining of the flexors and the extensors of the upper neck. And for those with temporomandibular disorders, is again, we need to diagnose them quite well, because we have several diagnoses of temporomandibular disorder. We have the clicking diagnosis, intra-articular, or the painful diagnosis, or also the degenerative joint disease. So according to this internal diagnosis of TMD, we can decide what is the approach. And again, dry needling and trigger point therapy will be a very important part, mainly for the pain-related patients. It will be very effective, the treatment of choice, I would say, in the short term, to reduce the pain from the muscle origin in these patients.
Are there also studies that report these effects?
Actually, we have today to the level of systematic review and meta-analysis, specifically for dry needling for patients with orofacial pain. It was published in the Brazilian Physiotherapy journal, and I think we still need to run more research in order to expand the knowledge and the data about the effectiveness and efficacy, but we are starting to see enough studies to support the dry needling approach for patients with orofacial pain and headache, definitely more than other regions. We have more studies than we have on the shoulder or on the knee or on the lower back. As far as I know, much more studies were conducted to support the dry needling for headaches and orofacial pain.
I think so, and also more medium term, long term than in the other areas.
Definitely, yes. And as a clinician that treats patients with headache, I can actually see it in practice. It works. It helps the patients to reduce the pain levels. And of course, it's not a standalone therapy. It's always part of physiotherapy, physical therapy, exercise therapy. But in the short and medium term, it's a very effective intervention to change the pain condition of the patient. And that's how we are changing also the pain perception, because the patients believe that it can be changed. And that's a very important thing to turn point for the patient to start to get better and to recover.
Yeah, yeah. So what would be your take-home message regarding headache and orofacial pain?
I think for physios, we need to classify the headache. We need to think using the traffic light approach is very helpful. I'm actually writing an article about it during these days, and it will be published, I hope, very soon. If we use this approach, then we have more order in our clinical reasoning for which patient we are likely to help, which patient we are not sure if we can help, but we give it a try. So this is the yellow. The green is we are likely to help. And orange is the patients that we are not very likely to help. Maybe it's better that they will not stay in our clinic if we want to have good results. And the red, of course, are the patients that we should not treat because they have a dangerous medical condition. So it makes more order in our clinical reasoning to understand, okay, this patient is going to improve. This patient, I'm not sure, but we give it a try. This patient, probably not. So let's not treat this patient. And of course, the red, I shouldn't touch this patient. This patient should not be in the physiotherapy, should be in a medical clinic and should be treated very carefully and quickly.
Yep. Perfect. Thank you very much. I'm looking forward to read this article.
Yes, thank you. Thank you for the interview. And thank you for inviting me to speak about this topic that is very close to my heart, because that's what I do most of the week. I'm dealing in the research and in teaching and in treating patients with the headache and orofacial pain. And I think it's very important that physiotherapists as a profession will improve the professionality and the accuracy in the treatment, because we can offer a lot to these patients. For that, I can guarantee we have a lot to offer to these patients with our hands, with our needling, with our exercises. We can help them.
That's a great last sentence. Thank you very much.
Thank you, Jacqueline.